It can also be later stage. So we're going to talk about both of those. And then there's two categories of stoma complications. The first one being skin conditions, and then the second one being changes in the stoma or problems with the stoma itself. So I'm going to start by talking about peristomal skin conditions. So you can develop, next slide, please. So you can develop a mechanical injury, and that's due to pressure or friction or medical adhesives on the skin. Things that really contribute to it is rough removal of the barrier. So you really want to be gentle with taking your pouching system off. When you clean the skin, you should be using a gentle technique. There should not be any scrubbing going on. Remove the barrier in the direction of the hair growth. That will help it hurt less if you happen to have hair in that area. Or you can wet the barrier with some warm water. I tend to frown upon using adhesive removers because if there's any residue left on your skin, you're just setting up your next product to fail. So try and avoid adhesive removers, but I do understand that sometimes you do need to use them. And then when you take it off, take the pouch off, you want to evaluate the system for the proper fit. And how you will determine that is by looking at the barrier when you take it off. Has it broken down pretty significantly, or is there stool on the skin? That's going to tell you whether or not your fit is good. If you do end up with this mechanical injury, and the picture is pretty prominent of what the injury looks like, you should talk with your nurse, a stoma nurse. And if your skin is moist and weepy, I do consider that you use stoma powder after you clean the skin, and then use a no sting barrier, either a spray or a wipe. Easier with the spray when you use the stoma powder, alcohol free. You can spray right over the powder and it keeps the powder in place. If you have to use a wipe, dab over the powder. There's enough in those wipes that will absorb into that powder, so it will make your skin nice and tacky. Now, irritant contact dermatitis. So this is an inflammatory response to chemical agents such as stool output. Babies left in dirty diapers get diaper rash. And so the same thing happens with your skin. You really want to make sure that we're keeping it protected. So this inflammatory response can be also to the soaps that you're using, adhesives that you're using, and typically you will feel some burning, maybe some itching. The area may look a little crusty, and sometimes there's some oozing of fluid, or you could bleed a little bit. Managing something such as this, either you can meet with a ostomy nurse if you have one available. You want to limit the products that you're using so that you can determine which are the products that you're allergic to. Change the barrier a little bit more frequently. So if you're going every 4 or 5 days, go every 3 to 4 days until you figure out what's happening. And if you do feel burning or itching, chances are there's stool on the skin. So you do want to change your pouch a little bit sooner. I would, as soon as you feel that burning, go ahead and change it. You do want to, in order to manage once the skin is broken down, either talk to your ostomy nurse, get a better fit with your pouching system, consider using convexity. And I just in case you don't know what convexity is, I don't know if you can see this, it's kind of raised here instead of being flat, as opposed to one like this, where it's completely flat. It's a level surface. That sometimes will help as well. And I would also recommend using an extended wear product. So each different company has different terminology for their extended wear. So Convatec's term is Durahesive. If you're using Stomahesive, that's not extended wear. So pick a Durahesive product. If you're using Hollister, their terminology is Flex Tend. If you're using a Coloplast product, their extended wear is called X Pro. They look the same as the standard wear, but they're made of something that holds up a little bit better. So you do want to consider that. If your skin is moist and weepy, again, do the powder, do the spray. If the skin is really bad, you can consider using Marathon. This is a great skin protectant. They're rather expensive. It's made by Medline. They're individual dosing ampules. So if your insurance covers it, great. If not, I think you can get them on Amazon. Health Products for You certainly carries it as well. Some insurances will cover, some will not. Excellent product though. Always good to have on hand for those needs. There you go, allergic dermatitis. So, so this is typically because your body is becoming sensitized to whatever you're putting on your skin underneath that barrier. And you can see it's got the whole outline of the barrier. So it's usually itchy and it can get pretty broken down and red. So you do want to limit use of products, again, if you're having this type of reaction, and consider patch testing. So take your barrier and use it on a different part of your abdomen and see if you break out in a rash. You can cut a little piece off of your off of the barrier itself and place it on another area of your skin to see if it's the barrier itself. Whatever kind of soap you're using. I personally don't recommend soap because they do leave residue, but if you are using soap, you might want to consider that soap. And also your barrier film. You may want to, I think I already mentioned that, try it on another area of your skin and see if you develop a rash. So how to manage it? Again, you can talk with your ostomy nurse who may give you some suggestions on different pouching systems that might work well for you. We do want to certainly remove what's causing that allergic reaction. Eliminate the accessories, use the bare minimum. And again, if the skin is moist, you're going to use either the Stoma powder with the barrier spray or wipe, and consider the Marathon as well. So fungal rashes, if you've never had one of these, come summertime, if you have your stoma, they're much more prevalent in the heat and humidity if you live in a warm area, such as the Northeast, where I am. So fungal rash is actually a yeast or candida. It likes warm, moist areas, and it starts to grow as a rash with little pustules on it. And then the rash becomes raised and it has some irregular borders. And as you can see in that picture, it almost looks a little shiny where it's close to the stoma. It can cause itching and definitely some burning as well. So how to prevent a fungal rash is you do want to make sure that you are eliminating moisture. So consider covering your pouch. Some of the pouches, such as Hollister and Convatec, they have that gauzy material on the outer part of the barrier. When that gets wet in the shower, it doesn't dry right away. And so you do want to make sure if you're not covering your pouching system during the shower, that that it's good and dry. You can take a hair dryer on a low setting to help dry it, again, or just cover it with a plastic that you can tape on your skin. Assess the wear time and removing that barrier. You want to check for the erosion or breakdown of any stool or moisture there, because again, that moisture staying there is going to make you more apt to get that fungal rash. If you get one, talk to either your nurse, your stoma nurse. You can call your surgeon. Sometimes you'll need an antifungal powder. There are some that you can buy over the counter, but there are good ones that are prescription strength, and that I would use instead of stoma powder if you're apt to have the fungal rash. And if you're diabetic, you really do want to make sure you're managing your sugars, because sugars not in control are not going to let your fungal rash heal. So folliculitis, and these are both excellent pictures of what folliculitis looks like. It is inflammation of the hair follicle. So every time you take your pouching system off, you're basically ripping those hair follicles. If you shave, sometimes you can get bacteria if you're not using a really clean razor. And this can cause inflammation at that hair follicle. So the first things you want to do is make sure you're being gentle when you're removing your pouch. If you're going to shave the hair on your abdomen, shave in the direction of the hair growth, not against it. But also keep in mind, you don't want to shave towards your stoma, because you don't want to take that chance of cutting your stoma with the razor. You can consider using electric razor. Electric razors won't give you this folliculitis like that. And then you do want to make sure your skin is nice and dry before you're applying your next barrier. So if you are going to shave, I do recommend that you use an antibacterial cleanser, such as dial soap. Dial soap won't leave a residue, and there's no moisture in that, so that's a good soap. Again, if you're prone to the folliculitis, use the electric razor, or if the hair is long rather than shave, you can certainly take a flat scissor and clip the hair rather than shave it. Now, pyoderma gangrenosum. This is an autoimmune disease. It's inflammatory. It's actually a little more rare, and we see it in patients with autoimmune conditions. It manifests such as Crohn's, people with rheumatoid arthritis. They have this active inflammation that just rears and can affect any part of your body. But for stoma, people with stomas, and we see this around the stoma, they're painful, they're crater-like, and they can actually start as purple in color, and then the skin just breaks down. Typically, I would see a nurse or your surgeon if you don't have a stoma nurse available, because these typically need to be biopsied, number one, and you do want to make sure that whatever kind of disease you have, such as Crohn's disease or RA, you want to make sure you're managing that disease. So, if you're on a biologic for Crohn's, I'll just use that because that's a very common one and why people have stomas. It just may mean that your flares are not well managed. So let's get you set up with that. Now, you could use something like a protective barrier sheet. This one happens to be by Coloplast. And it's sticky on one side, so you would peel the paper off after you cut a hole in the center to fit your stoma. With the wound, if you needed to put some type of dressing on it, and then you can stick this over it, and then place your barrier in your pouch. So that helps quite a bit as well. Sometimes wound care dressings are needed for ulcers such as this. And a really good one is something called the alginate dressing. And I'm just going to open that. It's kind of a felt-like dressing. It's very absorbent. It will absorb 20 times its weight in moisture. So you would cut this to fit whatever openings or ulcerations you have. Then what you would do is use one of these transparent dressings over it. Okay, if you've ever had an IV, well, you have an IV if you have a stoma. This goes right over that alginate dressing, and now your barrier will stick to this without any problem. So that's one way that we can manage wound care with your barrier and your ostomy pouch. Okay, so hyperplasia. Oh, next slide, perfect. So the hyperplasia, and this is pretty indicative of constant exposure to, you see it more for people with urostomies, but people with ileostomies can get it as well. So they're wart-like lesions, and they're caused by the residue in the urine for extended periods of time. So if you don't have a proper fit, then you're going to start seeing skin that looks like this. And cleaning it can be rather painful. So ways to prevent: make sure you have a proper fitting barrier. Use extended wear as opposed to standard wear. Convexity. A lot of your ostomies are flush with the skin, so I would consider using that convexity again. Make sure you're using a pouch. Urostomies have anti-reflux pouches, and it's built within the pouch, and it prevents urine from upflowing back towards the stoma. So that will prevent lots of urine exposure. And then certainly checking the pH of your urine. So you can talk with your doctor who can do a urinalysis, and they'll check that pH of your urine. And there is a product called ColiSeal. It's made by Torbot, and it's great for the urostomies. I apologize, I don't have one with me, but those help quite a bit. Also, I would consider Coloplast has that new protective seal. It has some moisture absorptive capabilities. So this way, if it is happening to leak on your skin, that moisture now can be absorbed into the seal as opposed to staying on your skin. So that's another great option. The other thing is you can clean your skin with white vinegar mixed with water. You do want to dilute it to about 1/4 strength. That white vinegar, the acetate in it, will help break down these crystals on the skin. All right, so changes with the stoma itself. The first thing that's pretty common if you've had a stoma for any length of time is a peristomal hernia. People who have permanent stomas, I think everybody who has a stoma will at one point develop a hernia because you do have a weakness in that muscle wall. So the hernia is actually when your intestine presses against the wall of your abdomen, and because there's a hole there for the stoma, that's that weakness. And it can sometimes protrude out through that hole and cause that muscle to spread a little bit. And so with that, it can, if you look at the picture, this is a very large stomal hernia. I typically don't see them get that big, but sometimes they can be difficult to pouch because they're very rounded, and you want to make sure to use maybe a barrier that's very moldable and will bend with you to go right around that curve. And Convatec came out with this convex flip, which is perfect for peristomal hernias. So you would put the wafer on this way, all right, cut it to fit. And once you place it over onto your skin, it rolls back. So now it's cupped. So now it's molded right to that roundness of your abdomen. And they do come in different depths. So if you have a very large hernia such as this, they do make them a little bit deeper. So, so that's a great option as well for hernias. The other thing you do want to watch for a peristomal hernia is skin redness around that skin that is now starting to become purple and painful. You want to hernias can get incarcerated. So that's what we really want to watch for. So typically peristomal hernias, they don't take you to surgery to fix it because with your stoma you have that weakness, it's going to reoccur. So they only will fix it if it becomes a problem with pouching and you can't get a pouch that works, or you're incarcerated. So your typical signs of incarceration, you're going to start to see redness there. You should have some abdominal pain. You may end up having some nausea and vomiting from that. And that means it's an emergency and it needs to be fixed, because that bowel can get stuck in that opening and cut off the circulation, and the bowel dies because it doesn't get blood flow. So you just want to really keep your eye on the skin and what's happening with that. If you have a hernia, again, we talked about some of those, some of the pouching systems that you can use. But to prevent one, avoid that heavy lifting. You want to avoid constipation. If you're going to be coughing and sneezing, say you have a cold and you're coughing a lot, put your hand over your stoma to counteract that internal pressure that's created when you cough and sneeze. They do make hernia belts. This one's made by New Hope. All right, it's elastic and it stretches, but it's reinforced so that you get the support right close to where your stoma is. So this is a great option if you're somebody who is very active and does need to do some heavy lifting or just to support that hernia. Coloplast also makes one. This one, again, it Velcro's closed, it's stretchy, and there's a section in it where you can cut a hole so your pouch can come out. If you need to wear these hernia support belts for any length of time, you don't want to keep your pouch enclosed in that because that's going to prevent the stool from coming out. So a prolapse of your stoma. This actually is where the stoma protrudes out. Now, sometimes you will see the peristalsis, especially with ileostomies. You'll see that peristalsis where it's moving in and out. And that's that wave-like motion that pushes food and your nutrients through your digestive tract. So it telescopes out and it becomes longer. Sometimes the base becomes larger because of that length. So if this is happening, you definitely want to see either a stoma nurse or your surgeon. Sometimes if a prolapse such as this, it's not a very large one. It shouldn't cause any pain, but you do want to resize the opening of your barrier to accommodate at that largest portion. Usually if you're lying down on your stomach, or not on your stomach, I'm sorry, on your back, if you do have any discomfort with this, just lying down can maybe help it go back in. You can gently apply pressure to it. If you are having pain, there's you can apply, take your barrier off, number one, but you can apply table sugar, just plain table sugar on a washcloth and hold that sugar washcloth over the stoma. What that does is it leaches out the fluid, so it reduces the swelling in it. And once that happens, you may be able to reduce it by pushing it back in. If it becomes very large or it's causing obstructive symptoms, such as abdominal pain, no stool output, you're having nausea or vomiting, that's going to mean you need to go to the emergency room to have that repaired. Again, use a flexible barrier. And actually, you may see color changes in the stoma. It may start looking really red. It may get very, very swollen. And if it starts to turn purple, that is, again, an emergent situation. So seek care by your surgeon, or I would go to the emergency room should that happen. Now, mucocutaneous separation. So, so this we usually see in the early parts, early days of your stoma. So you can see the suture line on the edge of the stoma separates away from it. And it can be only on one section. It could be completely around the stoma. Typically, these will heal and scar in as you go through that healing process. Usually occurs in the first 1 to 2 weeks of surgery. So the causes of this typically would be if you had a condition that delays your healing. Diabetes, you don't heal as well. If you're a smoker, that hinders your healing because smoking and nicotine is a vasoconstrictor. So if you happen to be on steroids for Crohn's disease or any other type of inflammatory condition, that will slow your heal time. Tension on the suture line, and that can, the tension can really just be because you have a lot of abdominal swelling or you have a lot of swelling of the stoma. And that can happen, or if you have an infection. So those are the reasons why we see them. Now, managing them, typically a stoma nurse would be the one to take care of this. Sometimes it's wound care, and as I showed you before, that alginate dressing with the clear transparent dressing over it, and that will allow your pouching system to fit. In my practice, what my surgeon prefers is that we just leave that open area incorporated into the opening of the stoma. So all that tissue, it It's made to have be exposed to stool, so we don't worry about the infection from the stool. So we incorporate it into the opening, and as it heals, each time you change your pouching system, you're going to remeasure so that that opening now will get smaller and smaller until it's just the stoma. That's how we handle it in our practice. Necrosis. So this we see within the first few days after surgery, and it has to do with poor blood flow to the stoma. Usually you have a lot of swelling of that stoma, and you'll see the one picture is all black with a little bit of yellowy greenish on it. And that's pretty necrotic, and it could be even just some portions of the stoma, small portions. And this is caused by swelling of the bowel wall. That's what cuts off your circulation or decreases it. If there's too much tension, so if you've got a lot of inflammation inside, say you had a perforated diverticulitis, and there's lots of inflammation there, and maybe you have an abscess that they had to clean out. Sometimes things get socked in from inflammation, and they are unable to really pull that bowel up above the skin to turn it and create a good stoma. So too much tension that can cause. If you are obese or overweight, sometimes that stoma can't be pulled high enough out because the level of adipose tissue in the abdomen it's a larger and thicker layer, so that can create a challenge as well. And then the last one is that the sutures placed are too tight, and they can become too tight again because of swelling. So what you really want to do is consult. Well, usually you're still in the hospital when this happens, but if it's occurring after you're discharged, you definitely want to contact your surgeon. You do want to monitor the color of that stoma, and typically in the hospital, they will use a transparent pouch because that allows nursing to watch that stoma and watch the color every time they do an assessment. And then when you're in the home setting, after you're out 1 or 2 weeks, you can go to that tan colored bag. Let's see, you definitely want to make sure your fit will accommodate any of that swelling that's going on. And then as this dead tissue sloughs off of the surface of the stoma, it can create a pretty foul odor because it's dead tissue. So some people will use deodorant into their bag just to help, because it's an unpleasant smell. But it will go away once it all sloughs off. Now, poor placement of the stoma. So typically we see this in emergent surgeries where the surgeon doesn't have time to assess the proper area to place that stoma. If you have a planned surgery, they mark the area that your stoma should be. It should not be right where you wear your pants. It shouldn't be right there. It shouldn't be placed in a fold such as this one. You want to be able to see it. So some people, if you have a larger abdomen, it should be placed a little higher up so that you can visualize and change the pouching system yourself. So what do we do with stomas like this? Certainly this fold in the middle creates a challenge with having a flat surface for your pouching system to fit and adhere well. So for some, we'll go ahead and use a stoma belt. I don't know if you've ever seen one of these. It goes right around your waist and it's got these little notches, and your barrier has these little belt tabs. So you would hook it right into here. Okay, and wear it, and you want to wear it snug. And what that does is it holds that barrier really tight to your skin. Should be snug, but it should not be really uncomfortable. The closer and tighter it fits to your hole is held to your skin, the less likely you are to leak. Other options are filling in these crevices, and you can use either stoma paste, you can use a moldable ring. Coloplast makes a strip paste, which is easy to work with. So you want to fill in that crevice to raise the skin so that it's more even, and then your barrier can sit on that because it will be a flat surface. If by chance you cannot get a proper fit, and I do see this, not frequently, but enough, no matter what type of solutions you have for pouching and getting better wear time, you just may need a revision of it or a resiting of that stoma. So we try all of the tricks of the trade, and the bottom line is if it's not working, you go back to your surgeon and say, I can't live like this. You need to recite my stoma, or you know, you got to fix something, because you shouldn't have to suffer and live with leakage every day, because that's not acceptable. Now, stoma retraction. This is a tough one. So stoma retraction occurs if there's too much tension. We already talked about some of those reasons why tension occurs. With that tension, it can pull the stoma back inside. So it's what we call an inverted stoma. To manage this, again, convexity is a must. And I showed you this is light convexity. I know it's hard to see that, but it's raised a little bit. This one, it's raised up even more. And then they have Coloplast has a deep convexity. This one happens to be New Hope, so they have a nice deeper convexity as well. These would be great options for a stoma that's retracted. Again, I would use a stoma belt, and when all else fails, see your surgeon and talk about a revision or a resiting, because that will make your life a whole lot better. So I do want to end by saying complications are very frustrating. They're frustrating for you as the ostomate, and they're frustrating for your ostomy nurse, because she doesn't want you, having to live like this. So when you leak a lot because you have a bad stoma, I know that doesn't sound right, but a bad stoma that leaks a lot, it can lead to isolation, and people tend to withdraw. They don't want to go out. They don't want to see their friends. They just stay home, and that's not good. You always have that fear of leakage in the back of your mind. So once all of you've exhausted all of the options to getting that right fit, then it's time to see your surgeon. And I'll end by saying managing an ostomy should not be difficult, and quality of life is important, and you deserve a good quality of life. Thank you.
Thank you, Christine. I cannot even begin to express what I learned today, not being an ostomate, but I learned so much about the kind of complications that do exist that I actually had. Even though I've lived in the ostomy world for the last 5 years, it's still very enlightening. Thank you so much for that excellent presentation. I would want to open up the forum. I don't see any hands raised yet, and I don't see any questions in the Q&A box or the chat box. But if you have a question, please feel free to raise your hand, and I will unmute you so that you can ask Christine. And there is no silly question. There is nothing that you cannot ask Christine. So please go ahead and raise your hand if you have a question for all right, I do see a couple hands raised. Okay, in the meantime, I'm going to allow Roberta. Rolf, if you could figure out your connections to see what's going on. Roberta, if you want to go ahead and ask your question.
Okay. Thank you so much this was great information, even though I've had an ileostomy for 17 years, so I really appreciate it. You mentioned the Maricon for skin.
Oh, Marathon. So here, use it up.
Marathon. Okay.
Marathon. Yeah, this is it's awesome product. If your skin is wet and weepy, this puts a dry coating over that moist skin. So now you have something for your barrier to stick to. You don't use powder with it. So once you clean your skin, you're going to crack this ampule. It's got a little sponge tip on it.
Okay.
And just wipe it over any area that's raw and moist, and it puts a dry coating over it.
Okay. I have a personal question. I've been using the same items for quite a long time, and I've just been having where it's not sticking on one side. And I have tried several things. I don't know what to do. I'm having to change every couple days or one day, 3 times a day, and it's just ripping my skin up.
Is there any change in the contour of your abdomen? Have you gained weight or lost weight?
I've gained some weight,
Okay.
not tons, but enough. It probably can make a difference.
Yeah, and so you might want to consider trialing a different manufacturer. Which company are you using right now?
I use Hollister.
Use Hollister.
Mhm.
There you can call the 800 number for Coloplast. They'll send you samples.
Okay.
Their product. You might find that things change as we get older. Okay. And maybe that whatever adhesive just isn't working for you right now. And so try a different pouching system.
Okay. All right. I'll do that. Thank you.
You're welcome, Roberta.
Thank you, Roberta, for that question. Rolf, do you want to try one more time? And if you cannot speak, then maybe you can type your question in the chat box. All right, so Rolf, why don't you try typing your question in the chat box and I can ask for you. In the meantime, I'm going to take Deborah's question from the chat box. Deborah is asking, how do you feel about stoma collars, Christine?
Stoma collars?
Collars, yes, stoma collars.
I'll be honest with you, 17 years, I don't know what a stoma collar is.
That is interesting.
Is it a belt? Is it one of these? I'm not sure because I've never heard of that term before.
Deborah, I'm going to allow you to talk if you think you can unmute yourself and share what you know about stoma collars. That would be interesting.
Can you hear me?
Yes, absolutely.
Yes.
You can. Go ahead.
I heard about it over the internet. I think it's not made in the United States. It's a company called SALT, S-A-L-T, that makes them. And it encircles the stoma and is supposed to help prevent leaks, I think. But it just kind of holds the stoma up. And I haven't tried it, but I just wondered if you've heard about it and what you thought about it.
So I haven't heard about it, although I have researched, there is a product I think it's in a testing phase, and I'm not sure where, but it is in another country. And it's actually a physical equipment piece that they implant when you have your surgery, and you're able to turn a valve on or off to allow the stool out. It's something very odd. And I did talk with my surgeon about it that I work with, and he said, yeah, there's enough complications out there already without having to add something artificial. That's a implanted piece. He seems a little leery about that. There is a product, and I'm not sure if this is what you're talking about either. Ostoform. It looks similar to a one of those rings. I didn't think to bring one with me, but this is a Coloplast convex ring. So it's very similar to the protective seal. I mean, it can stretch to fit your stoma. But that Osto seal is similar to this, but it's got a almost like a little slide. When you're a kid and you go down the slide, it's got a little area like that. So if your stoma sits like right at the skin level and the stool comes out facing down, or even if it's sideways, because you could always turn it sideways, that little slide acts as a guide for the stool, and it sticks out a little bit into the pouch so that the stool falls into the pouch. So if you've got a stoma that's more flush with the skin, you might want to consider looking into Ostoform.
Ostoform?
Form, yep, Osto, S-T-O, capital F as in Frank, O-R-M.
I have a urostomy,
Okay.
so would it work for that?
That's interesting. Is your stoma flush?
No.
It's not. So those osteoforms are really supposed to be for flush stomas. I guess it's worth a try. You can hook up with them, contact, if you find them on the internet, ask them for a sample, they'll send you one.
It's Coloplast?
No, that the company is Ostoform.
Oh, okay. Okay,
Yeah, they'll be happy to send you a sample. Hey, it can't hurt. I would try it.
okay.
Good luck with that, Deborah. I did get Raul's question, Christine, so it's in the question and answer box, so I'm going to ask it for him. He received an ileostomy in September of 2020. And the question is that what paste is best recommended for use with Convatec Eakins wound pouch 839262? Because the size of my stoma, most barriers are not large enough to provide protection, especially when my stoma prolapses. You want me to repeat any part of this, Christine?
No, so I got that. So it collapses, and I know those Eakin pouches, a lot of times they use them for wounds because they can be very large. The Eakin seal in and of itself is good, but you can actually try, especially for ileostomy, try using Coloplast protective seal. It's white, it's like a moldable ring. And you can break it, you can stretch it, you can use 2 at a time. They're kind of like silly putty, but I would use that as opposed to paste. Again, the moisture is absorbed into that, and so it's really going to protect your skin a lot more. If you need something like a strip paste rather than something in a tube, Coloplast makes a strip paste. If you are going to use a paste, a lot of them have alcohol in them. So if your skin is red or irritated, I know Coloplast makes a paste without alcohol. So those are some of the options I would try.
Sorry, I was not muted. Thank you so much, Christine, for that answer. I have one more question in the chat box from Carol. She says, I have a urostomy. What is the lumpy stuff that occasionally comes out when I empty my pouch?
So that actually, it's slough from the lining of the intestine. So with urostomies, they harvest a piece of your small bowel to use as that reservoir that your ureters get hooked to. So urine drains into this little portion of small intestine. So the little white flecks, and sometimes they can become pretty thick, or you might see a lot of them. It's really just sloughing of the lining of the intestinal tract. Nothing to be worried about. You just want to make sure that your bag doesn't get clogged.
Thank you so much, Christine. We're still taking questions. If anybody has any, you could raise your hand or type your questions in the question and answer or the chat box, whatever works for you. In the meantime, I'll draw your attention to the chat box. Deborah did ask me a question about the link for the support group, the ostomy support group. For those of you who joined us a little late, we do a webinar once every month, which is the third Thursday of every month. But we also do an ostomy support group, which is the second Tuesday of every month. And I've put the link in the chat box for the ostomy support group. Christine joins us in that support group. The difference between the webinar and the support group is that Christine picks a topic for every webinar and she dives deep into it and shares her knowledge and insight and takes questions specific to that topic. But a support group is essentially a support group. You can come in, talk, share your experiences, ask your questions. Christine is there. We also tend to have a product specialist in our support group meetings. So feel free to use that link. This link is also found in the footer of our website. If you're not familiar with us, we are health products for you. We are an e-commerce retailer of health products. And we also have a website called Shop Ostomy Supplies, which is just specific to ostomates needs. So these support groups and webinars are for our customers and for people who, it's not necessary. I will change that. It's not necessarily just for our customers, for everybody who we can support in their health and wellness journey. We are fortunate to have Christine part of our team. She's a wound care ostomy continence nurse who brings with her a wealth of knowledge because she herself is an ostomate. And that adds a whole other dimension to her knowledge about this field. So please feel free to ask any more questions you might have. I don't see any at this point of time. We'll wait a couple more minutes and then we'll call it a night. Oh, I just got one from Lenora. Her question, Christine, is that I have an ileostomy. I suffer with adhesions. Would you recommend a stoma dome? Whatever touches the stoma, I feel pain. For example, my clothes or just walking.
Oh, so that's an interesting one. You may want to consider a stoma guard. Stealth Belt makes one. In fact, that's the only one that I know of. But it is something that adheres to the top of your pouch, and then it bumps out a little bit so that it protects that stoma. It will prevent anything from touching it. So people who do contact sports, people that play racquetball, football, things like that, they use these stoma guards just to keep it protected so that nothing can injure the stoma. I would try that and see if it helps, because that will prevent your clothes from being on your stoma as well.
Thank you, Christine. If Lenora, if you have a follow-up question, feel free to type that in the chat box. Christine, I have another question from Raymond. He says, are there any serious dangers in accidentally allowing your urostomy pouch to completely fill? And Lenora says, thank you.
So yes, if the urine can't flow into the pouch, well, what's going to end up happening is as your pouch gets full, okay, it's going to balloon up. All right, eventually that urine needs to go somewhere. So typically it will start pulling away from your skin and you'll have leakage. But if you're not using one of those anti-reflux pouches for the urine, I would worry about that urine starting to leak a little underneath, and then you're going to get that that skin condition, that's that white and scaly area. I'm sorry, I'm forgetting what it's called at the moment. Oh, the hyperplasia, the pseudoverrucous lesions, that can occur from the urine. So yeah, I wouldn't let it get too full.
I hope that answers your question, Raymond.
Actually, you can consider attaching a leg bag to it. Some of the pouching systems for urostomies have a extension tubing that you can attach to make it a little bit longer, and then you hook a leg bag to it. So that can, it's an elastic that you can wear right around your thigh, and that will allow the urine to drain into that rather than sitting in the upper pouch. That gives you a little more leeway.
Thank you, Christine.
Sure.
So Raymond did acknowledge that and said, thank you. I have a note from Marcia in the chat box saying that she could not see the link for the support group. I did put that in the answer box again, but for those of you who couldn't see the link to the support group, if you would go to our website, it's healthproductsforyou.com. And if you scroll all the way down to where the footer links are, you will see one of the, in the footer, you will see a menu item that says Ostomy Support Group. And you just click on that and you will get to the link for the Ostomy Support Group. We are very thankful for you guys to join tonight and be part of this webinar. Feel free to reach out to Christine at any time. We do have again, in that same footer, there's a way to reach out to our experts. We do have Christine is our WOCN expert. We also have a respiratory therapist on site. So if you have, for all your health and wellness needs, we're your partners in that journey. For all of us to live a fulfilling life, no matter what our health conditions are, we believe that you can still live a full life with it. There is a way to live a full life with no matter what is limiting you health-wise. And we strongly believe in that, and we want to be your partner in that. I see a note from Michelle, I acknowledge that. Michelle is thanking us for this webinar. So Christine, thank you so much for the extensive information that you shared tonight with the stoma complications. We will see you all in our next webinar next month, or if you join us for the Ostomy Support Group, which is the second Tuesday in April. Please subscribe to our mailing list, because we do share the timings and the topics of our webinars, and also the timing of our Ostomy Support Group through our email list. So either go to shop.ostomysupplies.com or healthproductsforyou.com and subscribe to our email list, and you will get these in your inbox as reminders. James also is saying thank you for the informative webinar. Christine, I'm very appreciative and thankful for your time. Thank you, everybody, for joining us tonight. I hope everybody has a good rest of Thursday evening and a great weekend ahead. Good night, everybody.
Good night. Thank you.
Good night. Thank you.